We're not actually giving the chemo intrathecally or intraventricularly, but we're there for the whole process and handing the chemo and the check-offs, the whole thing. We're monitoring them if they're sedated, making sure they get their antiemetics.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS, and today we're talking with ONS member Rebekah Rabinowitz, neuro-oncology nurse at Emory University Hospital in Atlanta, Georgia, about oncology nursing considerations for intraventricular and intrathecal administration. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Rebekah.
Thank you.
So today we're going to be discussing two unique types of anti-cancer agent administration routes, the intraventricular and the intrathecal. So these routes are only used for a few select diagnoses. So many nurses, including myself, that we might practice our entire career without ever having firsthand knowledge or experience in what this administration technique fully entails. So today, I think we hope to demystify this for our listeners that maybe don't have that firsthand experience. To start things off, can you briefly explain what intraventricular and intrathecal administration types are, and how are they different from the types of chemotherapy administration that we are typically used to?
Sure. So both of them, intraventricular and intrathecal, intraventricular is into the ventricles and intrathecal is into the cerebral spinal fluid that surrounds our spine and brain. They both go to the same location. One is done by a lumbar puncture and one is done through Ommaya reservoir. They're used for different cancers and for different reasons, and they are used for prophylaxis, for chemo, and the IV chemo doesn't get to the central nervous system in the concentrations we need it to for the central nervous system to be treated properly.
I see. And I'm sure that's the whole blood-brain barrier issue that kind of serves a great purpose, but kind of gets in the way when we're trying to get therapeutics into that space.
Exactly.
Let's talk a little bit more in detail about the types of cancer diagnoses that we are treating using these routes and why are they used that way?
So they're primarily used in the liquids like leukemia and lymphoma. They're often used for prophylaxis of leukemic cells. And then they're used a little bit in solid tumor for leptomeningeal disease, which is when the cancer cells start coating the meninges of the central nervous system, which, is seen in pretty much end-stage metastatic disease.
And what about the types of agents or medications that are typically used in this administration?
So I have seen cytarabine, methotrexate, and hydrocortisone used. I've heard of trastuzumab or Herceptin being used. I have not seen that, but I've heard about that in breast cancer. And then I've read that TEPA is used, but I have never seen that either.
So maybe let's if you could, just take us through kind of a step-by-step of what sort of this standard administration process looks like for each route. And if there are similarities, then certainly we can address those in tandem. But just kind of walk us through, for those of us that might have not or may never experience this, what does it feel like start to finish?
An Ommaya reservoir looks like an easier procedure. To get the Ommaya reservoir, it is neurosurgery. It's a fairly simple procedure, but it's both the lumbar puncture and using the Ommaya reservoir gets the chemo into the central nervous system in the cerebral spinal fluid. And so for the Ommaya reservoir, a needle is placed through the scalp and into the reservoir. So it's, to me, very much like having a port in your head. Instead of going into your bloodstream, it goes into your ventricles where the CSF is. It's usually in your non-dominant ventricle, but they communicate. So they'll aspirate some CSF and send it for testing to see if there's cancer cells in it. And then they instill chemo into the brain. And it gets direct access to the cerebral spinal fluid. And it's a pretty simple procedure. A lumbar puncture is a little more invasive just because the procedure requires positioning where the patient is positioned in a way to create space between the bones in the back. So some people lay down sort of in a fetal position to get that spaces open. And some providers like to have the patient sort of lay over a table and stretch out their back, kind of like a turtle or a shrimp, they say. And then once they're in that position, they clean the area with betadine and alcohol. Chlorhexidine is contraindicated because it's a neurotoxin. So they clean it, they numb it up with lidocaine and place a sterile drape over it. And they use a needle to enter the cerebral spinal fluid space that they've already marked and numbed. It's in your lower back. It's not where your actual spinal cord is. It's where your spinal cord has ended and it's just nerve roots there. So paralysis isn't really a concern. It's an uncomfortable procedure. It's anxiety producing. So we often give some mild sedative, like we use Versed usually. It just takes a few minutes. The hardest part is getting into the actual spinal fluid. Sometimes it needs to be done in interventional radiology so they can see better. But a lot of them are just done in a procedure clinic, which kind of just does procedures all day long.
When drugs are administered through these routes, is it a one time and done sort of thing? Or is it something that has happened like on a cyclical basis, like our, IV chemotherapy that we're accustomed to?
So for leukemia, it's often part of the treatment plan. They might have it weekly, twice a week for 4 weeks during consolidation or something. I don't know the exact timing of it, but it's often part of like their intensive treatment. For leptomeningeal disease, that's sort of something that's done as a palliative measure, because once you have metastatic disease to your central nervous system, you're palliating at that point. You're still treating to get time, but you're not treating to cure at that point. With the leukemia and lymphoma patients, it's often prophylactic. Sometimes it's because they do have positive cells in their CSF. They're positive for leukemia cells in their CSF. Then they'll change up the schedule a little bit more and it'll be a little more intense.
So if there are repeated administrations intrathecally, do patients always get direct lumbar punctures, or do they ever have like a catheter, like epidural type catheter inserted in it, and that is used for repeated administration?
Or an Ommaya reservoir is the other way of getting the chemo into the cerebral spinal fluid. So lumbar puncture is one way and the Ommaya reservoir is the other. And Ommaya, that makes the procedure much easier, but there's a lot of risks involved in getting the Ommaya reservoir, and they can't always take them out. So a lot of the times, people who are not curable may get an Ommaya reservoir, but because it's something they have to leave in, they don't always have to leave it in. That's not a black and white situation. That's something that they would discuss with the neurosurgeon, but there is a risk of removing the reservoir from the ventricles. Like if scar tissue is formed, and there's risks of removing it. So usually just so that, a port is temporary, you can take it out very easily. So a lumbar puncture, it really is, for an experienced provider that gives it regularly, is simple procedure. It's anxiety provoking, the lumbar puncture, because you're putting a needle into someone's back and nobody really likes that. But it's not really a painful procedure. It's uncomfortable, but it causes more anxiety than it does pain.
Thank you for talking through those steps. That certainly is enlightening. And I think you touched on some very unique distinctions, especially with regard to the Ommaya reservoir, of how it might feel very similar to like a venous port and that type of administration, but the risks, like, as you mentioned, related to removal, and that can certainly impact the decision to use one or have one. So thank you for walking us through that. Let's talk now about the nurse's role in all of this, because that looks different when we're administering through these routes as well. So what type of special education or training do nurses need to be able to participate in the administration of anti-cancer agents when they are given through the intraventricular or intrathecal routes?
So a lot of it is safety and comfort to the patient. We need to be chemo biocertified for checking off the chemo. So even though I'm not administering it, I'm always one of the people checking it off. So there's often parameters. Platelets is one of the parameters we see. Have to be 50 for a lumbar puncture and 20 for an Ommaya. So often they're getting platelets before the procedure to keep it safe. So it's sort of checking labs, checking chemo, verifying it with them. A lot of the safety things, right? Drug dose, volume, rate, and route of administration. One of the things that has historically happened that's been dangerous is for a lot of leukemic patients, they're getting lumbar punctures with chemo on the same day they're getting IV chemo. And IV chemos can be really toxic when given in the cerebrospinal fluid. One of them that there's been mistakes made is vincristine, which is often given to leukemics at the same time as these intrathecals. And it used to be an IV push. They've since changed it that all vincristine has to be in a bag. It has to be dripped in because there were some incidents where the vincristine was given intrathecally and had deadly fatal consequences.
And so the vincristine, because it's meant to be intravenous, they put it in a little mini bag so that it makes, it kind of feels like this is supposed to go in the vein because this is a bag. You wouldn't hang a bag to give into an Ommaya reservoir. So it helps.
Syringe.
Right.
And you're really not supposed to have them in the same room, IV and intrathecal chemo administration. And again, like one of the safety things is making sure it's well labeled, which, we get it from pharmacy well labeled. And even though two patients may be getting the same dose, it still has to have their name on it. Getting things from pharmacy slows down the process of the LP because we have to wait for the chemo to be mixed and we have to wait on labs to be resulted so we know that we can give it safely. One of the other things nurses do is give antiemetics and sometimes sedation. So monitoring for lumbar punctures, they don't usually give a pain medication. They'll just some people get PO Ativan, some people get some IV Versed, and it's just to help them relax. You asked for special training. So it would be the chemo bio certification is one of the things that we need to have. And then safety for the patient, high-end hygiene, and then, putting on PPE, personalized protective equipment, just because chemotherapy has its own risks when it's being handled.
Sure. So, and this may be unique to each organization and kind of where and how they perform these administrations, but in your experience, if this is done sort of in an interventional or a procedural type of area, does the oncology nurse actually be the one there to represent and kind of do all of these cross checks to make sure that it's following all of our known and established kind of safety procedures from a chemo bio immunotherapy perspective?
Absolutely. So we're making sure everything is labeled appropriately, that their timeout is done before the lumbar puncture or the Ommaya reservoir being used, getting the LP kit out for the doctor or the APP that's doing the procedure. So we're not actually giving the chemo intrathecally or intraventricularly, but we're there for the whole process and handing the chemo and the check-off, the whole thing. We're monitoring them if they're sedated, making sure they get their antiemetics. And then after the procedure for the lumbar puncture, they have to lay flat for 30 minutes. So it's giving those instructions and making sure they're okay. And, there are risks for both of them. And we're looking for any acute neurologic changes that could be possible complications, which are rare.
So yeah, let's talk a little bit more about that then, the risks or those potential complications that we need to be mindful of, whether it's during the actual procedure or shortly after the administration through these routes.
It's not uncommon for people to get a headache afterwards, or even nausea and vomiting is not uncommon either when not given antiemetics. With antiemetics seem to do really well. We worry about aseptic meningitis. The chemo is just an irritant to the meninges, which is why they often mix it with hydrocortisone, is to prevent that chemical aseptic meningitis, which causes headache, nausea, vomiting, photophobia. It can cause altered mental status and even fever. Other things that can happen is some people can have seizures from it. It's unusual, but they're already at higher risk for seizures if they have any CNS involvement of their disease. And, one of the things we worry about for lumbar puncture is an epidural hematoma, which is why we want the platelets to be at least 50 because of bleeding. I haven't seen an epidural hematoma, but back pain is actually not a common complication or side effect of the lumbar puncture. There's usually some soreness from the insertion site, but there's not usually back pain where people can't get up and walk afterwards. The other risk is a CSF leak, where CSF leaks out of the needle puncture site, which can cause really bad headaches because basically you're dehydrating your CSF. Your brain just gets dehydrated and it hurts. And a lot of that is hydration, laying down, and caffeine that we give people.
There's interesting crossover. I've never done this in my professional life, but in my personal life, I've had a couple of babies. And so having an epidural and some of these symptoms are side effects after having that, that lumbosacral space invaded, both for good reasons, but some of those after effects and those risks, obviously there's some consistency across whatever the indication is. So those do ring familiar to me.
And when you're doing teaching with the patient, we often do bring up, it's similar to when women get an epidural when they're having a baby. It's the same space that we're using. We're using a smaller needle. We're not leaving a catheter in, but pregnant people do it every day. That sort of helps ease a little anxiety when they think about it that way.
So a lot of the complications that you had mentioned, what type of time frame do they typically occur in? Are they immediate, the hours afterwards, or could it be days to weeks that some of those things show up?
Usually it's the first 24 hours that we see complications. And with the pre-meds that we give, the antiemetics, people do really well. It's unusual to see someone have a seizure. That wouldn't happen immediately. That would probably happen during the treatment. Like if they're getting it twice a week for a month, it would be somewhere in that month that their brain may get irritated. You see it more in people that have active disease just because there's already stuff going on there. People that already have a seizure, a known seizure disorder. And if they did have a seizure, then we would put them on an anti-seizure medicine for a little while they were getting their regimen.
And as you mentioned earlier, there are some regimens that involve these routes of administration, but also in combination with other IV systemic treatments. And so some of the side effects might overlap, and it might be hard to tell what's causing what or where it's coming from, but just being aware of what could be attributed to the intrathecal or the intraventricular route, certainly important.
Oh yeah, these patients have very intense regimen of chemotherapy, and the intrathecal they're tired a lot of the time, between their oral chemo, their IV chemo, their hospitalizations, and then coming in because, everything takes longer than we would like it to for these patients. They're long days to come in for a procedure. When you include the lab time and meeting with the provider and, getting the LP and waiting 30 minutes afterwards and waiting for the chemo to be checked and administered, it's, one of the many inconveniences that our patients have to endure.
Unfortunately. And though some of that is built in intentional for safety. And so I think that's something that we always have to kind of bridge. Yes, there are sometimes it's just delay and frustration because of how things are fragmented sometimes, or just so many different departments and people are involved. But a lot of that, boils down to the importance of safety and having those specialized departments or clinical personnel doing the parts of the procedure that they are trained and best suited for. And so that just creates complexity. But you're right, it does make for long days. And so it's important to validate that for patients and acknowledge that, yes, this can be a long process. But sometimes I think giving them that heads up and just be prepared. The actual infusion or injection of a medication is very brief, but to get there, there's a lot of work that has to be done. So setting their expectations up to, just be ready for that, I think can usually help dispel at least some of the frustration that comes. So you touched on it a little bit when we were kind of doing the step-by-step walkthrough, but keeping nurses and clinical providers safe during the administration is important. So can you touch on some of the best practices for nurses to do that with regard to some of the safety steps as well as the PPE that we need to wear?
Yeah, PPE is actually for administering chemo. It's goggles, 2 gloves, and a gown. I don't gown up or put a face shield on because I'm not administering the chemo, but I double glove when I hand it to the provider who's giving the chemo. And I'm really just kind of shaking it out of the bag onto the sterile field. But, you want to make sure that the chemo's been labeled appropriately, that, it's not expired, that the timeout is done, where you check that it's the right patient, the right procedure, the right location, that the chemo has their name on it, that they've signed consent before they go ahead and do the procedure.
And as you mentioned, because this is often done in a more kind of surgical, procedural, sterile environment, as opposed to IV administration, the norms around wearing all of the PPE garb, even if it wasn't, in typical surgical areas, it's more for risk for infection and things like that. But I'm sure the expectation of the providers to wear that garb is not something that's pushed back on or questioned in the space where they're giving these types of drugs. Now, if we have providers in our infusion suites if they are ever involved in the administration there. I think there's probably going to be room for education and teaching our colleagues of like, what is the right garb to wear to keep ourselves safe? But I likely am expecting that that's likely not a hard conversation to have in a procedural area where there's already an expectation of maintaining sterility and keeping things very straightforward.
Sometimes you coach the doctors a little more than the...
That's exactly what I was just going to say, that I think as the oncology nurse in that space where, our mindset hopefully is and should be the importance of protecting ourselves and protecting our patients. And, I know over the past couple of decades, the feelings around wearing PPE have shifted over time. And I'm thankful we're in a space now where it is an expectation and nurses are aware of how it needs to be done and advocating for themselves to make sure that they have the right equipment and tools that they need to protect themselves. But it's taken us some time to get here. So
I've been a nurse for 24 years, and 24 years ago, we handled chemo very differently.
Yes, we did. But as you said, if the provider is not an oncology trained provider necessarily, or, they are trained in that procedure, but they do a lot of other types of procedures, I think the importance, again, of reinforcing this is not just for sterility. This is also because these drugs are hazardous and they have a risk to us, not just the patient. So that's really important, I think, for nurses to keep in mind. So if they find themselves in that space working with providers that maybe do many types of procedures, including this type of administration, just, highlighting and emphasizing the importance of wearing all of these different layers of protection, because it's for us. We have to keep ourselves safe too.
And to keep ourselves safe. Yeah.
We've talked a little bit of some tips and tricks as part of the patient education process, but let's dive a little bit deeper into that. Patients, I'm sure, have questions. They might not even be aware that you can give chemo this way or give any sort of anti-cancer agents through these routes. So what are some ways that oncology nurses can help ease their patients' fears, make them feel more comfortable about this part of their therapy?
Part of it is explaining the procedure way ahead of time. And then during the procedure, step by step as well. But, you have to meet their medical literacy needs. Like you said, they may not be aware that this even exists. Teaching them step by step, using an interpreter if you need an interpreter. And a lot of the time, one of the things that really does help is explaining that it's like an epidural. It's the same space that we use when a woman has a baby, and that, it is quite safe. And we go over the risks, but, their readiness to learn is an ongoing process. There's so much information overload in the beginning that it's just sort of repetitively going over what this is for and why they need it. Education is taking antiemetics and knowing when to call for side effects that we are worried about.
Well, let's talk through maybe that discharge instructions. As patients, if they've completed their procedures, we've helped them through it. They got through it. They were comfortable. They weren't too anxious that they're about to go home. So maybe what are some key points that we should be discussing with patients to help them be prepared for what to watch out for after they go home and when they should call back?
So we want them to drink lots of water, not do any heavy lifting, keep the bandage on for 24 hours, and then call for side effects such as, headache that won't go away, trouble thinking, back pain. Fever is not expected. We worry about meningitis, but even with an aseptic meningitis, you can see a fever. So it's something that, needs to be ruled out. And a lot of the time, these patients are pancytopenic from their other IV therapies, and you have to keep that in mind. That, infection and bleeding are real risks for them.
Absolutely. And so if patients do get this procedure, but then remain perhaps inpatient for other parts of their, induction or intensive therapies, are there any specific things that nurses should be monitoring or assessing for while the patients are still kind of under our direct observation?
You'd want to check the bandage that it's not wet and help take it off after 24 hours, monitor for headaches, monitor for nausea and vomiting, monitor fever. But a lot of the time they just need some Tylenol for the discomfort where the needle was inserted. We're not usually needing to give opiates or anything stronger than Tylenol for the pain. So that's important for them to know that it's, it's uncomfortable, but again, it's not really painful. It's just, people don't really like it, but it's not horribly painful. It's just uncomfortable.
Well, and it's similar, to an IV stick. We're using a needle, we're sticking it into your skin. Nobody likes that. So I think it's sometimes important to draw those parallels to maybe what they are familiar with, even though, as you've mentioned, like the idea that it's going into your spine or potentially into a reservoir implanted inside your brain, like that adds some additional kind of anxiety around what's happening. But when it comes down to it, it's also still just a needle into a space.
Exactly. You take the IV out and you put a Band-Aid on it and it shouldn't hurt too much.
Those are all great tips. And I think important points for nurses. Again, even if we as nurses are not directly experiencing this with our patients, if we're not working in that procedural area or we're not taking care of them directly, just knowing that patients go through these experiences and these types of administration techniques just gives us a more well-rounded understanding of all the experiences that patients can go through when they're getting their cancer therapy. So thank you so much, Rebekah, for sharing all of these details with us. It definitely has kind of given me a peek behind the curtain of what some patients that experience if they're getting their anti-cancer treatment administered this way.
Oncology has gotten so specialized and so much bigger than it used to be that there's so many little nooks and crannies that you can't know everything about.
Right. Absolutely. And I think what we're seeing, broadly is that this interventional type of care, whether it's administration of anti-cancer agents directly into, a unique space, we see that in various ways. Intraperitoneal, we've talked about intravesical in the bladder, but also we're seeing intraarterial, we're seeing chemoembolization, we're seeing things that, as you mentioned, are bridging kind of the worlds of procedure/surgery and oncology in ways that are unique and different, but growing. And so our role as oncology nurses, if we find ourselves either in those spaces or with proximity to those spaces, we can be a really great advocate for our patients and an educator to those other clinicians that maybe are unfamiliar or they're uncomfortable with the idea of, oh my gosh, this is a hazardous drug I'm handling. I don't know what to do. So we can really be, I think, a guiding light for those clinicians as they become more experienced in dealing with these types of agents and caring for our patients in their spaces. Well, to wrap things up, as we conclude our episode, we'd like to always ask just a few quick fire questions to help summarize some of the points that we've talked about. So to start that off, what are some common misconceptions about intraventricular or intrathecal administration?
I think the main one is that people think it's going to be a painful procedure. I've said before, it's uncomfortable. People don't like it, but it's not horribly painful. If, we do see pain that's concerning, it's likely going to be an ER visit for imaging and, just to make sure they're safe. But it's not a painful procedure. Women get epidurals every day. It's the same space that we're using. And I can't really think of any other misconceptions. I think people just don't really know about it.
We talked about training and sort of education that nurses need. Do you have any recommendations on where nurses can seek out additional information or training if they do want to kind of read up or learn more?
Oh, ONS's website is great. There's lots of stuff on the internet. I would ask your educator who should know about it. And the APPs we work with that are doing these chemos, they know a lot more about it than we do. But yeah, the chemobiotherapy class we have to have done to even check the chemo, even though we're not giving it. But, it talks about PPE, that's part of the training. It's not just handling the chemo, but it's protecting ourselves.
And then finally, are there any additional resources that you might point, patients in the direction of if they want to learn more about this technique?
I know the Leukemia Lymphoma Foundation has information on its website about the lumbar punctures and Ommaya reservoirs, because that's something that's not that uncommon for that population. It's harder to find information when it's used for leptomeningeal disease in solid tumor. There's really not a lot of information. We have some stuff from some of the drug reps that we could hand them, but a lot of it is just pretty much the same teaching that we do for people that are even getting it prophylactically.
Well, thank you again, Rebekah. I really appreciate all the insight that you've provided and taking some time today to talk with us. So do you have any final comments today?
Just thank you for inviting me to be your speaker.
Absolutely. Thanks so much. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.